Good morning, everybody. Well, I've lost count, I have to admit. Welcome to another MSNAP webinar. And I'm really pleased today that it's a special event on inclusion and accessibility for people living with dementia. As people know, I think it's a really, really important topic. And this today, I think, complement really well some of the topics we've covered before. And dare I say it, fill perhaps some of the gaps that we haven't already covered. So I'm really delighted with the range we have today. So basically, if you could just move on screen, please. Yes, I am today. You don't need to know who I am. I would introduce myself though. I'm Sarah Ghani. So I'm a consultant clinical psychologist. I've worked in Hounslow for about 20 years. So I'm the lead psychologist in our cognitive impairment and dementia service, which is now all older people's service as well. And also it's I'm the chair of the MSNAP advisory group. So I'm here just as chair of the meeting today. So I'm mainly going to do introductions. I'll keep an eye on questions. Before I go through the format for this morning, I'm very pleased that we did have 4 sets of talks lined up. One person isn't able to join us today, which is a real shame. I'm sure they'll perhaps join another time. So we've got 3 speakers, but we'll make the time work. So that shouldn't be a problem at all. If I can also just remind people that there is a day on driving and dementia on the 10th of December. So if people still want to sign up for that, please do go ahead with that. So for now, basically just in terms of how this morning runs, for those of you who may be familiar with it, but particularly for those who are new, if you have questions, please do use the chat box. Please type your questions in. If you can, mention who you're directing the question to. I'm going to be keeping an eye on that. We'll read them out. We're going to aim to answer them live. It does depend. There's a lot of people here this morning. Sometimes when we've had really large audiences, we haven't been able to answer every question that's come up. But basically, if we can't, we always will answer them afterwards. We keep a record of all the questions that have come in, so nothing gets lost. So we'll aim to answer and address all that we can, particularly while we've got the speakers still with us. But if we can't, we will come back to you. So next slide, please. Raise hand. I'm being reminded, I should be quite rightly. If you want to ask a question, please use the raise hand facility so that we know that you want to ask something. And I think speakers will say if they're happy for that to happen. I'm sure that they will be. There will be time for discussion as well. So we'll be able to keep an eye both on people raising their hands to unmute and speak, and also to kind of pick up the question and answers in the chat and the question and answer section as well. You can contribute, as it says, by raising your hand. We'll unmute you. And if you can confirm that you want to be unmuted to speak. If you're joining by some people, please press the asterisk followed by a 9 to raise your hand. Okay, so I have to say that's a new function on me, which is really useful to have. So asterisk and 9, if you just make a note of that. So you can still kind of alert us to the fact that you want to make a comment, even if you're not able to join us by the glory of video link. Okay, and again, you'll be informed when the host has unmuted you. Okay, on to the next slide, please. Oh, that's all the slides. I think that's all the instructions. I hope that's clear. I can see there's a little bit, and I think that's all that we need to do. So I look forward very much to hearing the speakers and to helping us all kind of have conversations to really pick up on the themes that come through. Can I start by introducing our first speakers for today? So they're Jane Nichols, who's a learning disability Admiral nurse, and Sarah Ormston, Dementia and Wellbeing Manager from the MacIntyre charity. So if I can now hand over, please, to Sarah and Jane for our first talk of the day. Thank you.
Morning, everybody. Thank you for joining and for being here. My name is Sarah Ormston. I oversee health, dementia and wellbeing for MacIntyre, and I'm joined by double act today.
Hi, I'm Jane Nichols. I'm the learning disabilities Admiral nurse working at MacIntyre currently.
So just in terms of answering Sarah's questions around when we'll take questions, if we can please take them at the end, that would be fab. I'm happy to take any questions at the end. Okay. Next slide, please.
So points we're hoping to cover over the next 20 minutes is a brief introduction to MacIntyre, We want to discuss the whole organisational approach that we take in improving health outcomes for people that we support, and also looking at supporting a timely diagnosis for people with dementia and a learning disability. Next slide, please.
So just a brief introduction to MacIntyre in case you've not heard of us. As it says there, we provide learning support, education and care for more than 1,500 children, young people and adults that have a learning disability and or autism across England and Wales. So that might be registered care services, we've got shared lives, supported living services, lifelong learning, we've got cafes, a whole variety of services that we provide to people. And I suppose fitting in that core to our values, we call it MacIntyre's DNA, and it's all around, you know, our vision is for people with a learning disability to live a life that makes sense to them. And what we thought we would, you know, talk you through today, we've been really fortunate. MSNAP have invited us before to their annual forum, and we've co-presented. You would normally, if you have seen me speak previously here, I co-present alongside, or we co-present alongside people with learning disabilities, and that is always how we've done it. Today that just was not possible, so I just wanted to take a moment just to apologise that we haven't got someone with a learning disability co-presenting, as you know, we do embody the nothing about us without us ethos, and that's really important to us. I've got 2 people on my team employed with a learning disability that usually co-present, and that's not able to happen today. Next slide, please. So just in terms of, you know, the sort of pathway, the journey that we've been on as an organisation around dementia, around 8 years ago, so even, you know, before 2016, we had a whole load of managers that were really skilled and but we're starting to support people with ageing population, and they said, you know, we need more support, guidance, help. We're starting to notice signs and symptoms of dementia, so we got that group together. They're called the Dementia Special Interest Group. We named them the Dementia Special Interest Group. Everyone there had a day job, and we were doing incredible work and sharing resources and meeting, you know, biannually. But what we were really fortunate is in 2016 we were awarded money from the Department of Health and Innovation strand to do a MacIntyre dementia project, a 3-year funded project. So that really was, you know, enabled us to accelerate the work that we were doing, and you know, across that 3-year funded grant, as it says there, we won 3 national awards, including the Dementia Care Award, for the work that we do. So we're really proud of that. And the funding ended in 2018. We have a legacy of resources because of it, which but this was far from the end of our commitment to people with a learning disability and dementia. And in partnership with Dementia UK, we appointed the UK's first ever learning disabilities Admiral nurse, who's on the co-presenting with me today. So I'm going to hand back to Jane for a moment.
Okay, so excuse me. So for those that aren't aware of Admiral nurses, they're renowned for their expertise in dementia and supporting families during times of crisis. So my role within MacIntyre is to support people pre and post diagnosis of dementia, ensuring and supporting a timely diagnosis so that we can look at the level of support that they require, and also look at environments that they live in and try and tailor that to their specific needs. So within my work plan, if you like, I have 10 main objectives that I need to achieve over the 2-year funded project. And this has been condensed into 4 key elements. So one of those is supporting circles of support. So that looks at everybody that's connected to the person that's supported by MacIntyre. So that can be family members, it can be external professionals that are actually supporting that person within our organisation. One of the other areas is working collaboratively across all disciplines. I would also be providing clinical leadership in terms of sharing best practice with support staff and frontline managers within MacIntyre. And I cover England and Wales within that service, so it can be anywhere. Obviously at the moment it is mainly via Zoom. And then the last but not least will be promoting health and looking at prevention education for the people that we support and also for the staff that support them. Next slide, please. So I know many people on this session will probably be aware of this, but I just felt I needed to cover it. So what is a learning disability? So it's estimated that 1.5 million people in the UK have a learning disability. And MacIntyre's definition of that is a learning disability affects the way a person learns new things in any area of life, how they understand information and how they communicate. So this can mean they can have difficulties with understanding new or complex information. Learning new skills can be difficult at times, and also being independent. Next slide, please. So I wanted to kind of just go through the links that we're aware of in terms of learning disability and dementia. So firstly, looking at prevalence. So as we know, there have been significant improvements in life expectancy of people with a learning disability over the years. It's believed that the number of people with a learning disability over the age of 65 has doubled in the past 5 years. However, as the learning disability population ages, so more people with a learning disability develop dementia or are at risk. So the risk factors. So as previously mentioned, we know people are living longer, and we also know that people with Down syndrome are at increased risk of developing dementia. In addition to the known risk factors of getting older, thanks to advances in modern medicine and improved care and support, whilst life expectancy of a person with Down syndrome has dramatically improved, we know we've still got a long way to go. So from the recent reports from LEADER, which have highlighted a stark inequalities to people with a learning disability, and their life expectancy and access to healthcare is still a concern to this group of people. People with a learning disability are also more likely to have additional health and social factors that are known to increase the risk of developing dementia, such as people with a learning disability are likely to have existing health conditions, physical health conditions. They're more likely to be overweight and inactive. They are more likely to follow an unhealthy diet, have limited social networks, so they're more likely to be lonely. And they're also less likely to participate in games and activities that keep their brains active. So the other area is looking at early onset. And if a person with a learning disability develops dementia, it is often at a younger age than a person without a learning disability. And the person will face different and additional challenges to people who do not have a learning disability. Excuse me. MacIntyre currently recalled at-risk database, which is based on NICE guidance. So we monitor people within MacIntyre that have Down syndrome from the age of 30 plus, and then people generally who have a learning disability at the age of 40 plus. And we hope by keeping track of this at-risk group, we're able to support a more timely diagnosis. So I guess the key points I wanted to highlight is we know dementia is not a normal part of getting older, but one of the risks of developing dementia is aging. Dementia presents much in a similar way to people with a learning disability, but the differences may come in a way you share information with that person, and the changes in the person may be slightly less obvious. The families and circles of support, so for example, social care staff, know the person really well, and it's really important that memory clinic managers listen and take note of what's being reported by their support staff and also their family members if they're involved, and to analyse that and look at what this actually may mean for this person. Next slide, please.
So we just thought we'd spend a couple minutes just talking through some of the health inequalities that people with a learning disability face. So one of the first reports I wanted to talk about, in case you've not heard of it, is the LEADER report, LEDER. It's funded by NHS at the University of Bristol. They've been doing research now into all deaths of people with a learning disability over the age of 4 since 2015. They've produced 4 annual reports. Their most recent one still shows that men with learning disabilities die 13 years sooner and women 20 years sooner. So there's significant differences compared to the general population in terms of mortality rates.
Okay, so over 80% of adults with a learning disability engage in physical activity, and this is below official recommendations.
Women receive less screening for breast and cervical screening. I think it was in 2018, the statistics were 86% of the general population received their cervical smear compared to 19% of women with learning disabilities. So, you know, there's stark differences there once again, and adolescents and adults with disabilities are more likely to be excluded from sex education programmes.
Poor access to mainstream NHS community services. So this can be based on the way that is communicated to people with a learning disability. If letters are sent out for appointments, they may not be able to read those letters, or they may just put them in the bin and not actually consider the implications of not being able to engage with those services.
And then we've got, you know, a lack of understanding, and not, of course, by all health professionals. We've got excellent ones, but there is a lack of understanding of learning disabilities, particularly within some GPs. And it wasn't until recently that, you know, the mandatory training for learning disabilities has been within the 5-year NHS plan is going to be moving forwards. Until then, training of learning disabilities wasn't on the agenda. So that, you know, means difficulty for people with a learning disability in accessing services.
So staff and people supported have a low awareness of the importance of healthy lifestyle, including eating a healthy diet and taking exercise. And this, again, has obviously impacted on those people's well-being.
And all of these points were from the VOG Tackling Health Inequalities report. So if you've not seen that, I would recommend going and having a read of that. This is a summary of the VOG Tackling Health Inequalities report. Next slide, please. So MacIntyre Way, what we're doing about, you know, all of these inequalities and how we're trying to reduce health inequalities for people. So the MacIntyre Way co-production, as I said right at the start, including and involving people we support in a meaningful way, side by side. We've got external partners, critical friends, and specialist champions and special interest groups. So I mentioned about the Dementia Special Interest Group. We've also got an Autism Special Interest Group within MacIntyre. We've got the Health Special Interest Group. So various, you know, interest groups to involve people. And we do have funding coming through, obviously, you know, trading income, charitable funds and grants. I think, you know, if I wanted to try and embody MacIntyre, you know, in one word, it is about the kindness, the compassion, the going the extra mile that our staff do, especially in these COVID times. You know, we've really united and come together, and I'm really proud of to be part of MacIntyre. Next slide, please.
Okay, so 4 areas that we've established that really works well within MacIntyre is equipping staff, reasonable adjustments, delivering good support, and sharing good practice. And Sarah's going to discuss these more in depth now. Next slide, please.
Okay, so one of the tools that I'm going to talk you through is the NHS's Anticipatory Care Calendar. So it's not made by MacIntyre, but I'm going to promote it for the next couple of minutes because it's incredible. So What works? Equipping staff. So we know a high priority for social care providers is the need to equip their staff with the skills, knowledge, and to advocate for people they support. We all know this. Regarding health, so that we have the confidence to engage in equal conversations with clinicians and other NHS staff. So how we've tackled this within MacIntyre and what we've implemented across the organisation is the Anticipatory Care Calendar. We call it the health calendar because it's more accessible to people supported, so I might use them interchangeably. But yeah, Anticipatory Care Calendar. So there are a couple of key documents that are involved with the calendar, and all of these will help receive a timely diagnosis for a person. So I'm just going to talk you through a couple of the key documents. So next slide, please. The first one, sorry, next slide. So there we go, thank you. The first one is the baseline health assessment. So we use this for people we support to record what's normal for a person. So we've, encouraged staff with families and everybody within a circle of support to really note down what is normal for a person. And that is so that in 2, 5, 20, 30 years time, if we go to a health professional and, we're starting to see signs or symptoms of dementia, we're able to have a document that records essentially what a person used to be like and their baseline health, which has been absolutely invaluable. And we've seen, by having a baseline health assessment, it's really enabled people we support to get not just diagnosis of support diagnosis of dementia, but of all health conditions. It's been a really powerful tool. So what it states is, it says not to be archived. We don't want it to ever be archived and put away. It's to stay with the person even in 40 years time. And what we do on here is we record, any diagnoses and illnesses the person may have, but we also record what's normal for them around bowels, sleeping, eating and drinking, communication, how the person shows they're feeling well, mobility. There's about 12, 15 categories of things that we record about what's normal for a person. We then have a monitoring health assessment that's the same document but a different title, so that we're able to go, that's what a person used to be like in 20 years time to someone, and this is the baseline health assessment, and this is what they're like today, and look at that difference between them. Our staff know people really, really well, but what we identified is normally it's in the mind. It's stuff that we just do naturally because we've worked with the person for so long. However, what we needed is a way of having a written record of the changes we're noticing, and this has been our tool. So baseline health assessment, first document. Can I have the next slide, please? So the next slide is talking us through the Anticipatory Care Calendar itself. It's to be used alongside the baseline health assessment I just spoke about earlier. So the first couple pages are dedicated to screening. We know that people with learning disability, with the top 5 causes of death, one of them is cancer. And so screening and, ensuring people attend screenings or encouraging is really important. So the first 2 pages are dedicated to the screening information a person we support is entitled to, the results of the screening and when the next screening's due. To support with this, we also made a poster. I'll come on to the resources we've made right at the end, and they're all free on our website. So yeah, 2 pages dedicated to screening. Can I have the next slide, please? And then what you'll see is just a screenshot of the calendar itself. So you've got numbers 1 to 31 going along the top, and they are your days of the month. And then you've got AM, PM, nights. And what our support staff will be doing is recording 3 times a day at the end of every shift the signs and symptoms of different health, different domains that people are we're noticing. So what this has enabled us to do, I've only got, the pain really screenshotted here for today. The health calendar also covers bowel movements, again, eating and drinking, problems swallowing, dysphagia, mobility and falls, any new signs of epilepsy, sleeping habits, it's really thorough, you know, made by NHS, not us, so I can't claim this to be my claim to fame. But what this enables our staff to do is to, you know, if they're doing this recording 3 times a day at the end of every shift, which they are, this is portable, it's, you know, take it on a piece of paper to the health appointment, and they say 18 times this month Bobby's been in pain, you know, a GP or health professional can no longer say, go away and record it and come back. It's all there for us, and we're really able to evidence every change we're noticing, which really empowers our staff and, you know, enables better access to healthcare, because we're able to evidence everything we notice. Can I have the next slide, please? Whistle-stop tour of this document. It just tells social care staff a description of what they're noticing and what to do about it. So you'll see there, for mild pain, for example, for someone with a learning disability, that could be that they're able to articulate pain, but they might have grimaces on movement, and then what to do. So that's really helpful for our staff again, and the circle of support. Can I have the last next slide, please? The final document is a significant communication sheet, where we explain, wherever we've gone into amber or red, what is the issue, what we did about it is the care action, and what, if a health professional got involved, what did they do about it, and the outcome. And this, you know, has been really beneficial to keeping a track of outcomes for people and improving and driving up quality. Okay, next slide, please. Back to Jane.
So talking about the anticipatory healthcare calendar, as Sarah just has, so this helps us support a timely diagnosis within dementia too. So it helps viewing health as an essential element of the support worker role. So they see that this is paramount to their role, is actually looking after that person's health and monitoring it closely. It empowers staff teams to advocate on that person's behalf, and also provide evidence to support any health changes. It helps to gives staff the tool to monitor any deterioration and a person's health, and communicate this effectively to relevant professionals, as Sarah's just discussed. It also provides feedback to teams. So with our dementia specialist interest group and the health specialist interest group, we can also look at sort of trends in different areas as well that might be happening, and helps us to address those. It helps us to follow our commitments to the Learning Disability Health Charter, and it provides us with an overview of patterns, noticing changes in that person's health, which again we can share with our primary healthcare colleagues. Next slide, please. So other areas I wanted to discuss in terms of supporting a timely diagnosis. So around preparing a person. So we've got the health calendar, and we've got the baseline health assessments that Sarah's kindly discussed earlier, and we can see how valuable that is. So other areas that might want to be addressed are preparing the person for their appointment. So I guess from a specialist point of view, it would be looking at considering reasonable adjustments for that person, so allowing extra time in appointments, which is also, you know, highlighted by NICE guidelines for the diagnosis process. Looking at the person's specific communication needs. Sending out pre-assessment information is another idea, so the person knows what to expect before they actually come to an appointment. And also it's helpful if the clinician can inform the staff of the kind of information that clinician wants to receive, so we know what to bring with us. Exploring and letting the person maybe visit the clinic prior to a formal assessment, to put them at ease and to understand the actual assessment process a bit better. It helps also to build trust with the person. The other point is sharing knowledge and sharing information, so keeping clear record keeping, which obviously from our point of view the health calendar gives us that tool, but also taking information from family history, talking to family members and also friends, obviously with consent from that person. The assessment side of things, so just looking at other possible health conditions that could be causing that person's behaviour to have changed in some way. So, for example, they might be experiencing a UTI, a urinary tract infection. Use simple sentences without jargon. Allow the person time to process the information that you're giving them and allow them time to respond. Sitting quietly is very difficult when you're waiting for somebody to actually respond. For some people need that extra bit of time. Consider what knowledge the person may have around the subject when you're asking questions in terms of the dementia screening. So questions like, who is the current monarch? That person may not know what the word monarch means. So it's kind of changing your language. Another good example is, which we've sadly seen, so in a recent health screening, was, tell me about an event you've been to in the last 3 weeks. Well, we have to remember that we're in the middle of COVID-19, the height of a pandemic, and actually, you know, that person hadn't been anywhere for 3 weeks. So it's okay to go off script. And following the diagnosis of dementia, you know, have that conversation with the person. It's a difficult conversation to have with anybody, but it's important that the person with a learning disability hears that from the clinician. And it helps the support staff then to guide them afterwards, talk through the treatment plans, support groups, financial advice, all the things that you would normally do. Next slide, please.
We will finish in 15 seconds, Sarah, I promise. Okay, so sharing good practice. We've got all these resources free on our website. So if you want, you know, booklets around timely diagnosis, signs and symptoms, treatments, change behaviours, all of that, we upload free to our website, www.MacIntyrecharity.org. So we share everything we make free for anyone to access. Next slide, please. And we are conscious that this is the start of our journey. So winning the awards and being recognised wasn't the end for us. We feel we're at the start of something. And last slide is any questions, please. Thank you very much.
Thank you.
So we have got one question, which is...
Thank you so much, Sarah and Jay. Oh.
No, I was just going to say we have got one question, which is, does the memory assessment take place in memory assessment services? And if so, does MacIntyre assist with that process?
Oh, you're on mute, Sarah.
Sorry. Sorry, can you just repeat the question, Miranda?
Yep, so it's, does the memory assessment take place in memory assessment services? And if so, does MacIntyre assist with that process?
I suppose, yeah, in response to that, it's where the person feels most comfortable is where the memory assessment should take place. So the one that you know, Jane spoke about, where we had the dementia assessment and, you know, they said in the last 3 weeks, what events have you been to? That was in the person's home. So that, you know, that was a good start. But because of COVID, it was done virtually. And that was really tough to do that. So I think, you know, yes, it's likely it could be done in the clinics, but I would say from a good practice perspective, and I know, you know, resources are tight and timing is tight and work plans, we're all crazy busy, but actually for it to be meaningful to the person wherever they feel most comfortable. And if that's in a park on a summer's day having a picnic, or if that's in their own home, we've got to do it where the person feels most comfortable.
Just, if I can just chip in there as well, it was really, I think it's remembering about the community learning disability teams that are in all the areas, the different areas. So if a clinician needed support with somebody to have a diagnosis or a part of that process, then they can always refer into the local community team and be supported by a community learning disability nurse who can work alongside the organisation that might be supporting that person as well.
Lovely, thank you so much. Lovely. Can I just say we've got one other question from Suzanne Hathaway. I work in older people's services. My main problem is building the relationships with the GP, as they often ignore physical health and just want a dementia diagnosis when there's clear physical health concerns. So it's more of an observation. I don't know if that's something that others are familiar with, or something that you're mindful comes up quite a lot?
Yeah, we see diagnostic overshadowing all the time, where the person we support, you know, GP or health professionals, you know, see the learning disability, and what we say to them is, you know, when we advocate on behalf of people is, you know, these are the changes we're noticing. We, you know, we've worked with the person for 30, 40, 50 years, and listen to, you know, and the health calendar, and that's where that's been really helpful, because actually it evidences exactly what we're seeing. But what it also, you know, enables us to do is use the lingo that health professionals, all of a sudden, if you're saying the Bristol stool chart rather than, you know, their poo, all of a sudden you seem to have more credibility with health professionals. So but yeah, I think forgotten the question now. I'm so sorry. I do this. I start talking and become passionate, and then
yeah. You've made the point that it's an observation about diagnostic overshadowing, like you say. I think that absolutely that happens. That does happen a lot. I have to say, it's really lovely to hear your talk. I might have mentioned before when you've spoken that I had an uncle who lived to 70 with Down syndrome and dementia towards the end, and 70 was a good age, given that he died about 20 years ago. I'm very aware, as a niece who only visited once every couple of months, I knew him incredibly well, you know, and just making sure you draw on that information, and just on the people who looked after me, and far better my aunts, is so critical, and of using that and not missing that. It's important in all dementia care, but even more so just amplified in caring and working with people with learning disabilities. So congratulations on your award. The questions I had, you've kind of answered. I was going to ask about accessing the resources and the expertise you had. The fact it's free on the website is amazing. So that's something we can all access and use. And I just love some of the ideas. I love the idea of the Anticipatory Care Calendar. It's just such a simple, but I imagine highly effective thing to have. And there's so many good ideas there. And the reminder just to do normal things otherwise. Make some changes, like you say, get somewhere where they're comfortable. Yeah, the preparatory visit I thought was a lovely idea as well. Again, sort of straightforward, but something we don't often do. But then to make sure that you do the normal things and have the normal conversations. So I think thank you so much for that. I'm just checking before we move on if there's any other questions. There are one or two more. I'm a little bit mindful of time. But if I can just ask them quickly, does the baseline health assessment or other documents discussed get shared with the GP? Is one question.
Yep, we take it to all health appointments to show them. That's the whole purpose, is to show exactly what we're seeing, and so we take it alongside the person. Yeah.
Yeah, and then there's another question that I'm just a bit mindful of time, but about somebody saying, for those who aren't familiar with the work MacIntyre does, to ask about the extent to which you work in residential care or community settings. Heard a lot about working with staff as opposed to families. If you can answer briefly, would I be right in thinking that you do work with families very much as well?
Yes, we've got a family engagement consultant within MacIntyre. Working alongside families is obviously absolutely core and paramount to what we do, and we're, you know, heavily invested in our families and have great relationships with families. And I think that also within the context of where the person that we support wants us to, because family relationships can be complex, of course, for anybody without a learning disability as well. And actually, you know, if we're providing support to the person, it wouldn't just automatically be assumed that the family's involved if the person supported doesn't want their family involved for any reason, but yes, we are involved with families, committed to families, listen to families. We've got family webinar sessions that take place, we've got family podcasts, we've got a family's Twitter account, so families is central to what we do.
Fantastic. That's a really good point to leave on, if that's all right with you. Thank you so much, both of you, for your talk today. If people have got other questions, type them in. If you think of something just in 5 minutes time, type them in. We'll be able to pass them on, we'll be able to sort of come back to them. Otherwise, it looks like it's this fantastic website with free resources that we can all go and use. So thank you so much. And if that's okay, I'm going to move on to our next speaker. If I can now introduce the next speaker we have is, I'm not very good at juggling my screens, so I've had to write it all down. If I can please now introduce Steve Hardy. He's a practice development nurse in Oxleas, and Matthew Roberts, an OT student at Cardiff, and hand over to them now for their talk. I haven't got the title in front of me, but I'm sure they will illuminate us very soon. So thank you very much again, and looking forward to our next talk.
Thank you. I'm afraid Matt is having a few technical problems. Oh, he's here now.
I'm
Hey!
Yeah.
Just on the go for it.
I'm down. I think we've got the same name on the screen, but my name is actually Matt, and we're here this morning to talk about a publication that we've been putting together over the last 6 or 7 months called Peter and Friends Experience of COVID-19. Like Steve said, I'm having a few technical difficulties this morning, so sorry if I cut out or freeze at any point, and I'm sure he'll jump in and rescue me. So yeah, basically what we've done is put together a book hoping to chart the experiences of people with intellectual disabilities or learning disabilities and or autism throughout the first and second waves of the COVID-19 pandemic, not just in the UK, but trying to get a global perspective on learning disabilities experience. So next slide, please. So this is the team that put the book together. On the top left, we've got Eddie, who is a professor of mental health and neurodevelopmental disorders and the secretary of the European Association for Mental Health and Intellectual Disabilities. The most important person on this slide is in the middle of the top row there. That's Peter, who is the man in the title and the inspiration behind this book. He's a self-advocate person with a learning disability who met Steve and Peter through Lewisham Speaking Up, and he was the inspiration behind this book. On the top right, you have myself. My name's Matt. If I'd have known this picture was going to be used quite as frequently, I may have put on a slightly nicer shirt or something, but that's me. I'm a postgraduate occupational therapy student at Cardiff Uni, former colleague of Steve's at Oxleas NHS Trust, and I also worked at Hounslow and Richmond NHS Trust before coming back to study. On the bottom row, we have David and Christine, who both work in the Foundation for People with Learning Disabilities based at South Bank University as the director and the head of programs respectively. And on the bottom right, in a very fetching mask, we have Steve Hardy, who's with me here today. He's a learning disability nurse at Oxleas, and he's also a lecturer at the Institute for Psychiatry and the associate editor of Advances in Autism. So next slide, please. So this is just a brief outline of what we're going to be covering in our talk this morning. We're going to, like I've just done, introduce the team who put the book together, and then talk about the reasons why we thought this book was so important and so timely. We're going to run through a few stories of people with learning disabilities. So we had a few discussions when we were putting the book together about terminology, and we wanted to stay well clear of referring to patients or service users because your qualification or your academic background doesn't necessarily make you an expert. In fact, people with learning disabilities are those most qualified to speak about their own experiences. So we're going to be referring to them throughout as experts by experience. But the book also captures the stories of people who work within health and social care, so people with a more professional background and more formal training. We're going to reflect on what would we do if it happened again? What lessons can we learn from the pandemic? And we're going to finish off by answering a few questions. So next slide, please. So first of all, we need to start with the reasons why we produced the book. So this gentleman in the photo again is Peter. And so in March, he was feeling a bit unwell. He was really worried and anxious because there was lots of stuff in the news about this new virus, and he was getting lots of mixed messages. So he got in touch with his GP because he wasn't able to sleep, and he had a really persistent, nasty cough. The GP told him to check his temperature, which was really difficult because he didn't have a thermometer, and even if he did, he really struggled with reading. And so he tended to have support workers coming in to visit him a couple of mornings a week, but because of the pandemic, those services were cut, those staff were put on furlough, and the outreach was stopped. So he felt really isolated. His college was closed, and he wasn't, like I say, able to access the written material, which was the only way the government was communicating a lot of this news. So he was really anxious and uncertain on what to do next. So next slide, please. So Peter reached out to Steve, who's here with me today, and they had a discussion. He told him about his anxieties and his concerns, and they discussed how there must be other people with learning disabilities who are going through similar experiences at a time like this. So it will be so important to give those voices a platform to make sure that this sort of historically marginalized cross-section of the population actually get their voices heard at the time of a global pandemic. So Steve reached out to some of his former colleagues, including myself and Eddie and Christine and David. So we all came together and we thought a book was a really appropriate platform. And so this book has been published online for free. It was launched at the end of October. And yeah, it's not for profit. It's just to share the stories of people with learning disabilities and make sure that their voice is heard and that we learn some of the lessons and stop and prevent the same mistakes being made again. Next slide, please. So through the wonders of the internet and social media, we were able to make this not just a story about London or the UK. We were able to contact people all across the world and make sure that this became more important than an attack on a specific government or specific policy, because so many of these issues we found through our research and interviews and transcripts, despite different sociocultural factors, we're all experiencing universal issues, and lessons that we can learn are global. Next slide, please. So we had contributions from almost every continent. So we had Australia, Ghana, Malaysia, Canada, all through the wonders of the internet were able to contribute to this book. And the stories were transcribed in different formats and written up in English. So next slide, please. So what does the book look like? This is the rough structure that the book follows. We have introductions and a bit of contextual work. So we wanted this book to be useful for practitioners and sort of academic circles, but also directly relevant to the people who the stories are about, so people with learning disabilities. So we tried to make it as accessible as possible to feature photos and visuals in a way that made it engaging and easy to access for lots of different service users. We then have lots of interviews and the experiences of experts by experience, so individuals with learning disabilities and or autism. We've also tried to capture the experiences of families and carers who may have taken on more responsibility or less, or they've been the ones trying to manage the increasing anxieties and concerns of people with learning disabilities throughout this pandemic. We also talked to professionals, organizational leads, managers, and talked about the challenges and opportunities that have actually been presented by the pandemic. So not all of these stories are negative. It's not, there's actually a lot of good that's come out of these interviews as well. Finally, we looked at the impact on mental health and anxiety and loneliness levels during the different waves of lockdowns across different countries. And finally, the lessons learned. So what will we do if this happened again, and what we can take forward? Next slide, please. So I'm now going to talk through a couple of the stories that we had before handing over to Steve. So the first story we had was from Wales. Next slide. Steve and I both interviewed a lady called Janice, and we thought this was a really nice one to start on because, like I say, the stories were a real mixture of positive and negative, of good and bad. It's not all damning or all positive. So Janice was a really nice interview because although lots of things about her life had changed, she wasn't able to go to the gym or the shops or go to listen to live music in the way that she used to enjoy. She wasn't able to see her friends, but she was really able to take so many positives out of the experience. So she talked about being able to watch all of her favorite TV programs, and also being able to stay in touch with family and friends through technology, through video chats, through things like that. Another really interesting thing about our interview with Janice was that she, whereas a lot of the interviews depicted the person with learning disability as very much the recipient of care and support, Janice was actually providing care and support to her brother throughout the pandemic. So there was a time where he was having to self-isolate, and she would have to do the shopping for him and then leave it on his doorstep. So the traditional kind of dynamic of their relationship was reversed because of the pandemic, and she was actually able to support her family throughout this really difficult time. So she was looking forward to things changing and opening up again. We spoke to her kind of in between the first and second series of lockdown restrictions, and things seemed to be really looking up. So Janice's story was one of a positive experience. Next slide, please. And then we had a story from South Africa. Next slide. So this was Michyle. Sorry if I've butchered that pronunciation, but his story was a little bit harder to read. He spoke really positively about his dreams and aspirations for the future. He'd actually, just before the pandemic, managed to secure his dream job as a groundskeeper at a local hospital for people with learning disabilities and intellectual disabilities. And he was really looking forward to saving up, to helping his mum buy a new car. He spoke about his favorite car in the world, a Toyota Corolla, and that was very much what was driving him forward. But unfortunately, the pandemic meant that hospital wasn't able to offer him the job anymore, and lots of things about his life changed. So he was worried about the increasing movement of gangsters in his neighborhood. He was worried about the way in which the army was used to enforce a really strict lockdown, and he really needed to be prompted and reminded by his family and friends to wash his hands, to wear a mask, to do all of these things that we've now all kind of got used to doing, but still feels so unnatural to someone who hasn't done that all of their life. And I think we tried to capture all of these stories in the person's own words. So I'll just finish off by quoting Michale's entry was written very much as a letter. So this is how he signed it off. He said, "Things are bad now in the time of COVID, but Mum and I, we keep hoping. I have my job, my plans for the future. I take it day by day. Sincerely, I want the future. P.S. My Toyota Corolla should be white." So with that, I'll hand over to Steve to talk you through a few more of the interviews that we did.
Thanks, Matt. Next slide, please. I think this one is from England. Yes. This starts off as a negative story, but ends up positive. Greg is quite a well-known young man. He works for Seeability. I'm sure you've all heard of this, but it's a charity that offer information and support for people with learning disabilities who have visual impairments. And this really affected him because most of their training is done, he does lots of travelling, and he travels face to face from his home in southwest London, even up to Cornwall, Wales, Scotland, etc. And he also travels with his colleague who lives on the Isle of Wight. So he would live by himself, but with support workers. He was really depressed, and he actually tried to commit suicide at one time. So he's immediately referred to the community mental health team and offered counselling. What they did realise, and he realised as well, that because he wasn't able to leave the house, he spent every day, near enough every hour of the day, watching the news, the negative news about COVID. So he'd watch BBC Breakfast News, then he'd watch it on CNN, then he'd watch it on ITV News, and then he'd look on the social media. And, you can imagine how much, being thrown into this life of all this really negative news about what's happening and nothing about the positives. So he got counselling, and they signed a contract with him. He arranged to watch one news programme a day. He chose the BBC News at 5 o'clock, the daily briefing, and he agreed never to watch anything else. That really helped him. He also looked forward to the cricket. He's also been to Lord's, the Oval, and places like that. He's actually gone to play snooker. Well, he's not doing it at the moment, but he actually has been out between the lockdowns playing snooker and darts. He hasn't been able to go and watch football, but I don't blame him because he supports Southampton. So he's from South London, he should support Charlton or Crystal Palace and not Southampton. Anyway, that's another story. He's really looking forward, well, he was at the time really looking forward to seeing his family and friends, and obviously he's met with them so far. And he's really, really hopeful for the future of going back to work for Seeability, because his whole life is devoted to Seeability, and he do such brilliant amount of work helping people in need. Next slide, please. Hola, amigo. This is from Spain. A lady, this is a foundation leader who I worked with in 2007 for 6 months at Guy's Hospital. She was on placement with us, which has gone up in the world since then. Now she is the El Presidente of a foundation. It's called the Alapa Foundation. It's based in Madrid. I won't read through every point of what's on the screen. You can read this, but to read, I mean, I knew she was a great inspiration, and she was going to do so well back in 2007. And I've seen her at a European Congress every 2 years. So we've met every 2 years since 2007. But I was really surprised when I had a chat with her. So she started up this foundation, which covers 3 areas. So sheltered employment, activities in the foundation's base, so art groups, etc., and also a parcel service. They actually, I can't believe this, this would never happen in England. If you disagree with me, so be it. But they won a tender to deliver all the parcels in the Madrid district. So people with learning disabilities, supported by support workers, were able to go out and deliver the parcels and also clean them. It's absolutely astounding. I can't believe that Royal Mail or DLR or Amazon will allow people with learning disabilities to do that. I may be wrong, but you can shoot me if I am. Okay. Next slide, please. This is just a picture from our foundation. These are some of the workers in the sheltered employment. Next slide, please. So they had 500 workers in the Alapa Foundation. They all had to go to temporary unemployment. So this is another really great impression of Almudena. They actually, they didn't get any, no one was put on furlough. So they were either going to be unemployed or the foundation were going to pay their wages. So they continued to pay their wages for 4 months until they were able to go back to work. So I think that's absolutely amazing. They also had to take a thoughtful decision. The decision was to make, shall we support the people with learning disabilities to go out and deliver the parcels? Well, these were listed as vulnerable adults. So just for the 4 months, they weren't able to go out and deliver the parcels. The support staff actually did. Next slide, please. This is a picture of 3 of the people or gentlemen with their parcel delivery bits and pieces, but that's actually in the foundation, and it just shows what extra work they do there. The artistry, it's a really colourful place. I did have a ticket to go to see and interview them all in this May, but then 2 days later they blocked us going from Spain. So I've got a voucher, and hopefully I will be able to spend it to go and see Almudena and her colleagues again sometime soon. Next slide, please. Yeah, I won't read through all of this, but it's the last 2 sentences. And moreover, it was a very important moment to shine and break prejudice about the value of people with learning disabilities. It reminded me of women in World War II and the image we were all still remember of their value. That really struck a point with me. And also I write quite a few blogs, and one of my blogs I put a picture up starting with from 1940. It was people sheltering from the bombing, so they were down in like Angel Tube or London Bridge tube stations, etc. And above it says 1940 or 2020. Yeah, so it just tells you that story. And yeah, hopefully we're coming out the other end at the moment. Next slide, please. So what if it happened again? So do we think we've all learnt any lessons at all about people with learning disabilities and COVID? Next slide, please. Me and Matt, we had the luxury of interviewing 3 organisations. I've worked with 2 of them. Bexley MenCap, so we interviewed about 15 advocates. Lewisham MenCap, again about 15 to 20. Peter's actually a member of them. And Share Community, they're actually a college in Clapham, South East London. Next slide, please. So all in all, we interviewed about 45 to 50 people, and we asked them, well, what would you like to happen, or what would you like the government or the NHS to know how to improve the care of people with learning disabilities if we was in another lockdown? Okay, so number 1 was include people with learning disabilities in simulation. The Lewisham Speaking Up group, they participate in loads of training simulation. They do that at the Maudsley Hospital in a proper built simulation studio. But they also were talking about, I think it's Aldgate, it wasn't Angel, it was Aldgate tube station, about 2 or 3 years ago, where they did a major simulation where someone rang up, said, I've set off a bomb, it's going to go off in an hour. So the police, the fire brigade, the ambulance and every other helper that could turned up, and some everyone was actors except for the fire brigade, etc. But we had a look and we couldn't find one person with a learning disability was employed. So if you look at the facts that Jane mentioned earlier, 2 people in every 100 should have a learning disability. So 1 person should have a severe to profound learning disability and 1 should have a mild learning disability. Now, we realise it's very difficult for people with profound and severe learning disabilities to understand and appreciate what's going on around them, and it would be very scary for them. But there are loads and loads of theatres around this country. I've worked with them in Wimbledon. I've made quite a lot of videos with them. And, you know, why couldn't they employ them to be the actors? So one of them could act as a person with a severe learning disability, and 1 could act as a person with a mild learning disability. They should be included. Inclusion is the key. Also, there's a task force set by the government. Hopefully, fingers crossed, Chris Hatton, who I've known for some years, and also he helped Matt out recently. He's a really well-known worldwide professor, and fingers crossed, touch wood, but he would have included people with learning disabilities in the government task force. And I've also read the outcome and report from the task force, and they come up with the same recommendations as our book. So they said that people with learning disabilities should be represented on every local authority, NHS and government forums regarding the COVID. All information should be in a variety of accessibility. I can't remember, Fatma her name was. She says one rule isn't for everyone. So she was quite angry about the use of easy read. And easy read information is given out at every meeting I've ever been to. But they said there's more other ways of doing this. So you can use short videos on YouTube. You can do audio tapes, a variety. So that's a project we're taking forward at Oxleas, based on this lady who, if she was up for PM, I would vote for her, definitely would. More support, especially for people live by themselves, who sometimes have outreach, and more guidance that's clearer. So I'll give you 2 examples. First of all, a man called Lloyd, he was admitted to Lewisham Hospital. His story's in the book. He's in A&E and they told him he had COVID-19. So he agreed with that. 4 or 5 hours later, he's taken up to the ward and they said, you've got coronavirus. Well, he panicked. He said, I'm going to die. I've got 2 diseases. And he started screaming, etc. They calmed him down and they said, well, COVID and coronavirus is the same thing. So we really need to agree on the terminology we're all using. Another term that people really didn't understand, especially if you know people with autism, they didn't understand the term support bubble. So we did a role play the other day and I just used an image. I said, like from Harry Potter, I've forgotten the name now, Harry Potter 5, where Auntie Petunia, she's blown up of air and she just floats off in the sky. So I imagine that if I was put in a bubble, my bubble would float across the Atlantic. And unfortunately, if seen by President Trump, he'd probably shoot me down as a terrorist. But you know, people with autism sometimes think like this. They take things virtually, literally. So we need to be very careful about the information. Next slide, please. As Matt mentioned, it was launched on the 29th of October. Next slide, please. We were based all over Europe, actually. There's 4 of us. We were based at Queen Mary's Hospital. About 15 people were based around the country, but they were also generally at Cardiff University. We had someone from Madrid, Richard. Yeah, so people from all over Europe. What I was really proud of was something Jim Blair said. He said, I don't call it co-production, I'd call it fusion. Yeah, so that's my new term now. I use that once a day, at least. Introduction was done by Peter and Eddie. A Raspberry winning role play was performed by myself and Elaine. I was playing the patient from hell and Elaine was playing the calm and patient GP. Interview with Almudena, and also I'm going to do an interview with Almudena on a vlog or a podcast pretty soon, so you can look out for that. We had some interviews with experts by experience. And we were so pleased that Sir Norman Lamb, he actually introduced the day. He was such a, you've probably seen him on the news so many times. He's such a brilliant speaker and an advocate for people with learning disabilities. Hayley Newman, who founded the Downside Up. Luckily, she's got married and her surname is now Newman, because I cannot ever pronounce her last name. Hayley Golorgan, no, I can't remember now. Anyway, It's a really, really long name. So the Foundation for People with Learning Disabilities, they talked about staying mentally well. And Cardiff University Vox, who Matt sings with. If you've ever seen if you're my age, you'll remember the Brady Bunch. If you're Matt's age, you won't remember the Brady Bunch. But on the Brady Bunch, all the people, all the family, the large family, all in boxes, and everyone's singing. So it was a lovely, positive song. I'm really thankful to Cardiff University Vox, and they sung Castles. So you can look them up on YouTube. Perhaps invite them to some event you're doing. I mean, I don't want to book up their diary, but yeah, they're really talented. Next slide, please. The book is available. The address
Steve,
there.
sorry, it's Sarah here. I've been completely absorbed. Steve, can you hear me?
Yeah.
I'm so sorry,
Yeah,
Steve, can you hear me?
Yes,
I'm sorry.
I can.
I've been completely absorbed. I've noticed that time has run away a bit. I'm really...
That's it. I've only
Would you
got
be able
one
to
more
just
slide.
do the last one quite quickly? Is that okay?
Yeah.
I've got to absorb and not check the time.
Yeah.
Lovely.
So you can download the book, but we're making a few tweaks to it. So I wouldn't print it out until next Monday. So we relaunch it then. But gratitude is our attitude. We really like to thank everybody who submitted stories, and to all of those who supported the project. As it said, Matt said at the beginning, this was done in our own time, without funding, and we really appreciate all the help we've got from everyone. So thank you. Cool.
Thank you so much, Steve and Matt. Thank you. That is amazing. I have to say, I did get absorbed. There's just so much in there, and so many of the stories are so relatable. And again, it's fantastic that you've made a resource that people can access so easily and download. So I absolutely will be. And it's just nice to hear the relatability of stories, things like watching the news and having to cut that down, but the change of roles, so people picking up different roles during COVID, so many things we never might have anticipated. So thank you so much. I can't see any comments in the questions. If it's all right, I'll move on. And if any other questions come up, pass them on to you. Is that okay?
Yeah, cool.
Thank you.
So now.
Our next speaker isn't here, so it... Oh gosh, okay. Thank you so much. Take care.
Thank you.
So
Bye.
our final speaker today is, thank you. A bit of a segue in terms of the issues around kind of seeability and visual impairment, because we now are moving to Dr. Keir Young, who's a senior research fellow at Dementia Research Centre at UCL Queen Square. So if I can hand over to you, Keir, I'm sure you can introduce what you're going to be talking about. Thank you.
Thank you, Sarah. Can you see my screen? Yeah?
You can.
Great, and thank you so much for having me here today. So my name's Keir. I'm a research neuropsychologist at the Dementia Research Centre, Queen Square Institute of Neurology. And I work with people living with various degrees of dementia-related visual impairment. Such impairment refers to difficulties perceiving what or where things are, with these arising not from any eye condition, but rather from the diminished capacity of areas, particularly towards the back of the brain, in interpreting and representing visual and spatial information. So crucially, today I'm going to be talking to you about difficulties with people's brain sight, not with their eyesight. Dementia-related visual impairments are common yet under-recognized consequences of Alzheimer's disease and other neurodegenerative diseases. A substantial proportion of patients with Alzheimer's disease who present normally on ophthalmological examination may exhibit higher order visual impairments, and these can include difficulties in judging depth, in perceiving faces, for example, in having difficulty discriminating the gender of faces, having particular difficulties perceiving things in peripheral relative to central vision, or in locating where things are in visual space. so-called visuospatial impairments are routinely assessed with figure copying tasks, for example, where people might be asked to copy these intersecting pentagons, or visual search tasks where people might be asked to cancel out a certain letter or number on a page. And some recent work suggests that of 4,000 patients with so-called typical late onset Alzheimer's disease, roughly 10 to 16% may exhibit relatively prominent deficits on such visuospatial measures relative to measures of episodic memory or executive functions. Visual symptoms are core clinical features of forms of dementia other than Alzheimer's disease. For example, early complex visual hallucinations experienced in dementia with Lewy bodies. Visual symptoms may arise in forms of dementia where the initial complaints relate to difficulty in people's memory, language, or motor functions. And this is consistent with the progressive nature of the disease spreading to affect areas particularly towards the very back of the brain. And perhaps unsurprisingly, dementia-related visual impairments fundamentally limit a whole host of everyday activities, ranging from independent eating, dressing, to conducting activities such as reading, or navigating one's everyday familiar environment. We learned a great deal about the nature and basis of dementia-related visual symptoms through working with people living with a condition known as posterior cortical atrophy. In the last 3 decades, the terms posterior cortical atrophy, or visual variant of Alzheimer's, or more colloquially Terry Pratchett disease, have often been used interchangeably to refer to a neurodegenerative syndrome which is characterized by the early and progressive loss of visual functions. While the most common cause of posterior cortical atrophy is Alzheimer's disease pathology, consistent with the term posterior cortical atrophy, literally meaning back of the brain shrinkage, PCA patients tend to demonstrate reduced cortical thickness and grey matter volume towards the very back of the brain, so the posterior parietal and occipital temporal regions presented here in yellow and red, and actually increased cortical thickness of the medial temporal lobes compared to patients with a more typical memory-led form of Alzheimer's. Correspondingly, PCA patients demonstrate relatively preserved episodic memory function, at least at earlier stages of the disease course. Now, in contrast to more typical and well-recognized dementia syndromes, where the earliest symptoms might relate to difficulty in people's short-term memory, difficulty with planning, or word-finding difficulties, some of the earliest symptoms of posterior cortical atrophy include problems with driving, difficulty with reading, often with patients becoming lost on a page of text, and in particular, difficulties perceiving or locating objects presented in clear view. And to give you a sense of some of the visual disturbances experienced by people with posterior cortical atrophy, I'm going to present a clip of a lady with PCA who's being asked to describe what she sees in this photograph. So this is a photograph of Brighton Pier, and the recording was taken around the time of the London Olympics.
It looks like a park or maybe a station or buildings. It looks a bit like the thing they're trying to elect for the Olympics. Or it could be the beach. But down here looks a bit sandy. It looks like Brighton, something like that.
So you get a sense of her picking out individual parts of the scene. At one point she says, could be the beach, or could be a building site, possibly referring to the supports of the pier. But she seems to have difficulty piecing together these individual parts into an overall whole. And this notion of being able to perceive parts, but not the whole of things, is something that's reflected in the great deal of often striking accounts provided by people living with posterior cortical atrophy. And over the next few slides, I'm going to go into particular detail about some neuropsychological symptoms that can be quite characteristic of posterior cortical atrophy, but can also arise in later stages of more typical Alzheimer's disease, secondary to people's initial memory complaints. Complaint to many people with posterior cortical atrophy is a particular difficulty perceiving or locating objects presented amongst cluttered environments, with reports such as this underlining the tendency of objects which are close together to sort of merge or combine into one unrecognizable object. Now, prompted by comments such as this, myself and colleagues carried out a series of investigations to get a better understanding of the nature of so-called cluttering effects, and in particular, under what conditions such effects might be reduced. So we started off by presenting very simple stimuli to 26 people with PCA, so these letters presented in isolation. People's ability to perceive these letters was very good. People barely made any errors. Having presenting the same letters but surrounded now by visual clutter, so these other letters, shapes and numbers, we identified a tendency for patients to start making errors, but this tendency towards cluttering effects could be reduced in a number of ways. Firstly, by simply presenting objects in isolation. Secondly, by increasing the spacing between the central letter and any surrounding visual clutter. And thirdly, by using visual clutter which differed maximally in contrast relative to the central target. Now, a striking and often counterintuitive consequence of posterior cortical atrophy includes a particular difficulty perceiving large relative to small objects. And this is something that was neatly summarized by a patient who attended clinic who mentioned that they had a great deal of difficulty recognizing the newspaper that was right in front of them. However, when we're looking towards the end of the train carriage they were sat on, they had a great deal less difficulty recognizing the very same headline that someone else was reading when presented at a distance, i.e. when that headline was perceptually smaller. And while this particular difficulty perceiving large relative to small objects has been noted across a range of studies of posterior cortical atrophy, its basis is still unclear. There's some suggestion this might reflect a restriction in the effective visual field, where objects of a certain size are extending into peripheral vision and thus are more difficult to perceive. Where this has clear implications is in asking the question, well, what are appropriate aids, support strategies, or accessibility requirements for people with diminished visual function owing to dementia? For example, you might have someone with posterior cortical atrophy who could go to a low vision clinic and say, I've got difficulty with my reading. They might be provided with some aid or technology which would blow up the font size of text, if anything, making it more difficult for that person to read. And prompted by some of the really life-limiting consequences of dementia-related visual impairments, over the past few years, we've been conducting a body of research, core to which involves harnessing the unique perspectives offered by people living with posterior cortical atrophy, who are experiencing dementia-related visual symptoms at the earliest stage of the disease course, to get a better understanding of dementia-related visual impairments arising in later stages of more typical dementia syndromes, but at a point whereby people's concurrent difficulties in their memory, language, and insight can make it that much more difficult for them to articulate any visual experiences they might be having. Ultimately, we hope to develop practical aids and strategies that mitigate for the effects of dementia-related visual loss, and to achieve these aims, we've adopted interdisciplinary and collaborative working between neuropsychologists, social scientists, engineers with an interest in adapting the built environment, and people with a lived experience of posterior cortical atrophy and memory-led Alzheimer's disease. Through conducting a series of home visits, we've gained an idea of parts of the home that people not only with posterior cortical atrophy, but also more memory-led Alzheimer's disease are struggling to negotiate on a day-to-day basis, for example, cluttered environments like so, as well as any strategies, if any, patients and caregivers are currently implementing to manage parts of the home. So presented here are examples of the strategic use of contrast in picking out objects in this cluttered environment, or emphasizing the position of a certain object around the home. Presented here are examples of more elaborate lighting-based aids, often operating on the principle of emphasizing a certain destination around the home or floor path to a destination, commonly intended to facilitate people getting to and from bedroom and bathroom at night time. Through working with colleagues in UCL's engineering department, we conducted out a series of pilot investigations within an accessibility laboratory that can really be described as a large warehouse space. And within this space, we construct different settings which simulate everyday domestic environments, but crucially, we can take aids informed through our basic neuropsychological investigations, or strategies which have been shared with us from individual patients and caregivers, and we can see whether introducing these aids or strategies into any of these environments facilitates the ability of people with PCA and people with memory and Alzheimer's disease to reliably and confidently find certain destinations or objects. To give you an idea of what it's like from the perspective of a participant, I'm going to present a point of view video taken from a lady who was diagnosed not with posterior cortical atrophy, but with typical memory-led Alzheimer's disease. She's been asked to walk through the open door that you can see on the far side of the setting. The circle shows her recorded gaze position, so where she's looking as she's carrying out this task. So you get a sense that she's taking that much longer than you might expect to locate that target destination, possibly owing to inefficient visual search. Though having fixated the door handle on the target destination, she gets across to it without any obvious difficulty. So a recurring theme throughout any of these accessibility investigations is in asking the question, well, what are the optimal conditions of the physical environment for people with various degrees of dementia-related visual impairment to reliably and competently find certain destinations or objects? And so for the first of these investigations, we were interested in whether the introduction of simple visual cues based on strategic use of contrast or visual motion might facilitate navigation to a visible destination. Presented here is an example combined contrast and visual motion cue. Our interest in this motion effect was prompted by patient reports of seemingly being better able to locate moving relative to static objects. No reference was made to the presence or absence of any visual cues. We were only interested in making changes to the visual environment. Our primary outcome measure was time taken to reach destinations, and in a combined patient group, we found evidence of patients overall being most efficient reaching destinations in the presence of a simple contrast cue. We didn't find any evidence of the added benefit of this visual motion cue. Now, an advantage that this accessibility laboratory offers is it enables us to quantitatively investigate certain patient reports that can be somewhat counterintuitive. And a common complaint of many people with posterior cortical atrophy, as well as something reflected in focus groups we conducted with care home staff, includes a particular difficulty when negotiating certain surfaces where there's a lot of perceptual variation. By this, I might mean flooring where there's a lot of stark shadows, glare, reflection, or garish pattern carpeting. Correspondingly, we conducted an investigation not of overall lighting levels, but rather the consistency of lighting within a controlled setting. And by adjusting the position of overhead lighting and the layout of the room, we were able to create three so-called shadow conditions. From left to right, these are high, medium, and no. Again, our primary outcome measure was time taken to reach destinations. We find evidence of effects of shadows in the PCA, but not typical Alzheimer's disease control groups, where PCA patients were at their most efficient reaching destinations under the no relative to high shadow condition. I'm going to briefly present some motion capture data. So this is based off movement sensors attached to participants' feet. And this is a bird's eye view of people with posterior cortical atrophy walking to both left and right-hand side destinations. Not only can you see some examples of these indirect paths, and this is just walking to a destination a few meters in front of participants, but overlaid are these dots that show individually slow steps given an individual's usual walking speed. So we consider these to be a way of reflecting, for example, hesitant steps. And there's a suggestion that the tendency towards these hesitant steps is decreased when minimizing shadows interrupting the flow path to destinations. Now, as mentioned briefly earlier, a common and often debilitating consequence of posterior cortical atrophy is loss of reading ability, which manifests often as people becoming lost on a page of text. To give you a sense of this difficulty, for someone with PCA, rather than reading out this text in the following order, the most outspoken judge on the US Supreme Court has defended the use of some physical interrogation techniques. But this person with PCA has read out the text in the following order. The most outspoken judge in the Supreme Court has defended, and they go back to the first line, supreme, the most, the BBC, could be in the face. But from conducting formal investigation of text reading ability, or the group of people with PCA, we identified that people's reading was quite good for certain words within passages. Presented here in a darker shade of green are words that are read out more accurately, more consistently in a group of 15 people with PCA. There's a suggestion of more accurate words to be clustered towards the beginning of paragraphs, and also on the perimeter of paragraphs rather than towards the center of each paragraph itself. And this is consistent with the notion that words towards the center of paragraphs are less susceptible to these cluttering effects. And following such work, we trialed reading aids based on a very simple premise that reduced the amount of words that could be adversely acting as visual clutter by presenting text in chunks, one or two at a time, rather than all at the same time, might promote more accurate and pleasant reading. And with using such serial text presentation techniques, we provided evidence of people's reading accuracy, so that's people with a diagnosis of PCA, increasing from around 50 to 60% with standard text presentation to more like 90 to 95% overall. And some subsequent work led by my colleague Ida Suarez-Gonzalez has incorporated these findings through the process of co-design with a group of people with posterior cortical atrophy, two of whom had previously worked as software developers, to develop assistive technology to promote reading as an independent activity into the disease course. And I'd particularly like to thank all the participants and caregivers through both their involvement in research, as well as their activity in peer-to-peer support groups, not only in initially steering these avenues of research, but later on in helping to fulfill its translational potential. I'd like to thank all of our participants and caregivers for their time in being involved in research, and you for your attention. Thank you.
Thank you so much, impeccable timing. Thank you very much for that presentation. There was, again, so much information in there, and a lot of it, actually, it's the sort of stuff that was so much I need to go back and absorb some of it more, but I think it's such an important area because so many people don't pick up on these visual issues, and having this sort of understanding about what could help, what's actually going on in more detail, I think is hugely helpful. So I'm just going to see if there's any questions. I don't think there are. I'm just having a quick look if anybody else has seen any questions. Does anyone have any questions out there that I've missed? Not that I can see. Okay, thank you. Can I just ask, Keir, are there things that you think we should be doing on a day-to-day basis, which there's so much in there that might be sort of priorities for us working in dementia services and memory assessment clinics to pay more attention to? If there's always like sort of one thing to kind of definitely remember amongst the richness of what you said.
So I thank you. I think a couple of things jump to mind. So in short, I think, again, for a lot of neuropsychologists, ideally, it's about evaluating someone's overall profile rather than interpreting tests by the numbers. And for a lot of people, again, whether they're experiencing these cortical visual impairments, again, these brain sight difficulties, whether it's at the earliest stage or whether it's someone who's at intermediate stages of Alzheimer's disease, who's developed prominent secondary visuospatial problems, it's about thinking about how that can confound some aspects of the assessment. For example, memory measures where they might have quite a prominent visual component, and thinking about how to adapt those again to promote accessibility. So going for things like joint visual and verbal presentation for where you have memory lists based off verbal stimuli. I think it's also worth being conscious about how those can impact, again, day-to-day independence and the implications for psychoeducation. So sadly, I've worked with at least a couple of people who were diagnosed initially with typical Alzheimer's disease, and caregivers have said things like, for my wife, she was missing things around the home. I'd ask her to grab something from the cupboard and she'd say it's not there, and I'd say it's right there in front of you. And this caregiver would say, oh, I thought she was being passive aggressive or showing behavioral problems. But then I realized after a while that it was a symptom of the underlying disease itself. The other thing I'd quickly signpost to is we put out some training for people like optometrists and also with the Royal College of Occupational Therapists. So if you work with any OTs, I'm very happy to signpost to some of those CPD materials.
That would be really helpful. I might welcome back to you on that. Thank you. That'd be really useful to know, because I agree. In my experience, it's more common than people often think that you can have these problems presenting first, and if you don't pick that up or kind of don't assess carefully enough, it can be a real issue. So, thank you so much. Oh, I think there's more question and answers. Thank you. Very interesting presentation. Good for understanding. A really detailed and concise summary of PCA. Thank you. Tricky to detect. In Kirklees, we're working with Stirling University Services Development Centre, who have an international reputation for dementia designs. That's interesting to hear as well. And finally, are there any leaflets used for PCA? I have a lady who's been diagnosed, but not accepting the diagnosis. So that's just, so yes, the CPD, the links to the information for the CPD, if we could have that, that'd be wonderful to share through MSNAP. And any obvious leaflets or sites to go to?
So I would strongly suggest checking out the Rare Dementia Support website. So this, again, provides both services for people living at risk of rare forms of dementia. They also have a research aspect and an education aspect, but broadly, they enable peer-to-peer support groups, and those can be also just for caregivers. They also run some bereaved support group meetings, and they've just started out also doing support groups, I think, for children, because often the people we work with have younger onset dementia. So I would suggest checking them out. I'm sorry to hear about the client who is having difficulty coming to terms with the diagnosis, but I think first port of call, rare dementia support would be something that comes to mind.
No, thank you very much. Somebody just said thank you for that website. I forgot about it. Me too. As soon as you mentioned it, I remembered it. Absolutely. Somebody just also said, can you differentiate between sight loss due to macular and PCA, and what happens if a patient has both? I don't know if you can answer that quickly.
It's a really great and really important question. So just to emphasize, I'm not an ophthalmologist or a neuro-ophthalmologist, or I'm not a neurologist or a psychologist. But yeah, I am aware of people with PCA who not only have PCA, they also have macular degeneration. And so I think one key aspect of this is how to adapt the standard visual acuity assessment. So with the standard visual acuity chart, you've got all these lines. There's a couple of confounds with posterior cortical atrophies. Often people will get lost from one line to the next. So for some people who have what's been termed this inverse size effect, in some cases they might have more difficulty with some of the really large items on the chart. So the way that some optometrists will adapt this, and I think Gordon Plant and your ophthalmologist also suggested this, is just to show items one at a time so people don't get lost. And there's also less susceptibility to these crowding or cluttering effects that I've mentioned. But in short, it's not a trivial thing to do, and I'd probably be most comfortable doing it, again, with involvement from really a specialist neuro-ophthalmologist.
No, thank you. It's a very complex area. I think people have really appreciated the level of detail you've gone into to sort of help people's understanding. So thank you. I am mindful of time. I'm just remembered that I'm meant to be in a meeting, but I'm sure they won't mind me being a bit late. Thank you so much. There are a few other questions which we will pick up and pass on and hopefully answer. And we've got resources from all the speakers, which is absolutely amazing, about ideas about where to go. So if I can just thank everybody who's spoken today and perhaps bring us to a close, if that's okay. I thank you to Cassie, Claudel and Sinead for facilitating so wonderfully, as always. Otherwise, if there's nothing else to say, I probably don't want to drag it out. If I can just thank you all and remind people just one more time of the MSNAP Driving and Dementia webinar on the 10th of December. I think it's more of a workshop, a slightly longer event. I'm really impressed. We had one speaker down and we still went over time. I think there's just so much rich information. It's a real testament to the speakers today. So thank you very much, and I will sign out and let you all get on with your days. Thank you.